I'm one of the cardiologists here. I've been living in Appleton for about 3 years now. I moved up here from Chicago to join this group, and I've always was practicing down there, downtown Chicago for 11 years, and did a lot of vascular work down there. It's probably half my practice, and that's a lot of the reasons why these people, these doctors here, wanted me to come up here, is to do vascular work and to kind of help build the program for this cardiovascular department. So the talk today is about peripheral arterial disease, and a lot of people don't really know what that is, and you may or may not have heard the term PAD. So on TV, probably in the last 5 or 8 years, they've started to throw around the term PAD. And so PAD is peripheral arterial disease, and I think a lot of it is because you'll see the commercials on TV where they say, ask your doctor if you have PAD, because they want to sell you their drugs. So it's probably appropriate, but it's kind of brought PAD a little bit more into the public awareness than it was before. So probably a little bit of good thing. So what is it? So PAD is basically peripheral arterial disease, a fancy way of saying blockages in the leg arteries. So they probably could have named it something simpler than peripheral arterial disease. They could have just named it leg blockage or something, lab or blah or something, I don't know. But it probably would have been, everybody would have already known what it is, and maybe I wouldn't have to give this talk. But basically it's blockage in the arteries in the legs. And there's a lot of other arteries in the body. There's carotid arteries, there's arteries that go to the kidney, heart arteries, but heart arteries, coronary artery disease, and for some reason leg artery disease is a peripheral artery disease. Sometimes you can kind of use the term, and it sometimes encompasses carotid artery disease in some articles. So how do arteries become blocked to begin with? This is kind of one of the most basic and important things in all of cardiovascular medicine. How does this happen, and what do we do about it? So this is a cartoon of an artery starting over here when you're like supposedly in your first decade of life. So before 10 years old, each one of these represents a decade. So teens, 20s, 30s, 40s, 50s. And basically the first thing that happens that arteries become blocked is you start to develop plaque buildup. So you start to get a cholesterol deposit in, what do you do? Sure. Burn it out.
All right, plug back in.
Yeah.
It's like a reset button.
I wonder if it was, I barely tapped that cord with my toe. Should I kick it?
What I'm going to do is, just to be safe, in case this thing confused.
That's probably what it is.
Yeah, I'm just going to grab another.
So
I want to talk about vascular screening while I'm doing it.
That's in here. It's worked in. So the plaque buildup, you can kind of remember what that looked like. The cholesterol, basically, that's floating around the bloodstream, is part of the normal part of the bloodstream, will, when there's some inflammation in the walls of the artery, that'll start to build up in the walls. And it really depends a lot on your genetic makeup and what other risk factors you have as to what else will build up, what if the cholesterol builds up in the wall of the artery. But what also happens is there's a layer called a cap that's between the cholesterol and the inside of the artery. So that cap protects the bloodstream from being exposed to the cholesterol that's actually inside that plaque. If there ever becomes a little tear, or we call it a rupture, in the cap of that plaque, then the blood is actually exposed to that cholesterol and that plaque that's in the wall of the artery. When that happens, the blood will try to repair that little tear or that little rupture in that plaque. And the way it does it is it forms a little clot on that tear. So if you would think if you would cut your hand, you're going to develop some bleeding, and then you're going to develop a clot on that cut. And that clot is the beginning of the healing process. Same goes for inside the artery. If you're if you develop a little micro tear in the inside of an artery, the blood will clot on that. But an artery isn't very big. So a heart artery is probably in the range of 3 millimeters in diameter, sometimes 4 for a very large one. Arteries in the legs, they can be as big as 10 millimeters for these larger arteries up in the pelvis. In the thighs, they're probably in the range of 5 to 6 millimeters in diameter. So if you think about that, that's probably smaller in diameter than my pinky finger. If you develop a clot on the wall of an artery, and if the clot gets too aggressive, meaning if it starts to collect, it can start to block that artery.
Okay.
Sounds good?
Yeah, sounds like kind of
Yeah.
There it is. I think what I'm going to do is turn the lobby lights down a little. You know, we're getting a lot of sunlight in. That might help a little bit.
So this represents a little tear in the plaque right there, and a clot forming on that. But that clot can get carried away, and if it's a narrow vessel, it can actually block that vessel. The clot itself can block the vessel. And the third thing that can cause a blockage is if you get what's called an embolism. So an arterial embolism is a little clot that comes from somewhere else and gets stuck in the narrowing. So if you have atrial fibrillation, you can develop a clot in your heart, and those clots can kick out and they can go to areas in the arteries. Well, they're bound to get stuck in the narrowest spot. So if there's a narrowing in an artery and a tiny clot, it can get stuck in that narrowing, and then it can finish the plugging up process of that artery. So some quick facts, just some, we call it epidemiology, but quick facts about the peripheral arterial disease. In the United States, it's estimated that 8.5 million people have this. Up to 20% of people over age 60 have peripheral arterial disease. That's a large segment of the population, 20%. Interestingly, 40% of people with PAD don't have any symptoms at all. And that's going to become important in a minute. Men and women actually have equal chance of getting PAD. So here's a graph that shows how it increases with age. If you take a look mostly at the white bars, it's a study of about 8,000 people. It was quite a while ago, but it showed that less than 10% in this age group of 50 to 59. If you come over here, 75 to 79 is getting close to 20% of people have PAD. When you hit the 80 to 84, it gets up about 40%. And then in this 85 to 89, it's up as high as 50% of people have PAD. So who gets it? Besides, we mentioned getting older, it naturally gets more prevalent. The strongest risk factor for PAD is smoking. So smoking, active smoking, increases the chance of developing it by 4 to 6 times. Really the next strongest risk factor is diabetes. And it's a little bit strange, but smoking tends to affect the arteries above the knee more, and diabetes tends to affect the smaller arteries, which would be below the knee more. Chronic kidney disease is a medium potency risk factor, so people that are on dialysis have a very high chance of having PAD. High blood pressure, high cholesterol, and family history all come into play. Those last 3 things come into play with any plaque building process. So what are the symptoms? So the medical term we use is claudication, and that it's kind of a funny word, but it comes from the Latin word claudicare, which means to limp. So it means to limp or be like gimpy, or to not be able to put your weight on one leg. So what happens is if there's not enough blood supply to an artery, you might be fine when you're resting, but when you start to walk, that muscle needs more blood. It needs more oxygen. So as you walk, and if there's a restriction in that artery, you may not be able to get more blood to where you need it, and eventually you'll start to build up lactic acid. So the feeling of lactic acid is what you would feel if you ran up a flight of stairs and you feel some burning in your leg when you get to the top, but then after you rest for 30 seconds, it goes away. If you have a blockage in the leg, you may get that burning if you're just walking from here to the car out there, or you may get it at shorter distances. But practice. to sit on your leg. So really you develop a tightness in the leg while walking. It's not really a sharp pain. In fact, it's not a sharp pain. It's a squeezing, and it eventually turns into a cramping. So the symptoms are brought on by walking, they're relieved by rest, and they're almost always extremely predictable. So you'll be able to say, I know I'm going to get it when I get a block and a half away from my house, and if I rest for 2 minutes, it'll be gone. Then I'm good to go again. I can walk another block and a half. It can be in the calves, the thighs, or in the buttocks.
No.
So it depends on where it is in the leg as to where the symptom is. So if the blockage is up here in the pelvis, that's up above the hip. So here's the hip, here's the knee. If it's above the hip, then the symptom can be in the buttock, the hip, the thigh, or the calf. If the blockage is between the hip and the knee, it's almost always going to be in the calf, sometimes the ankle or the foot. If it's at the knee or below, usually the symptom will be in the bottom of the calf, ankle, or the foot. If the blockage becomes worse, and it has to be pretty bad, you may have symptoms actually without walking. We call these resting symptoms. And you can have an achiness, and these usually if you have more than one level of blockage, you can have an achiness, and it's usually in the foot. And a lot of times it'll be gravity dependent, so people will say, my feet ache when I'm in bed, and sometimes I have to hang them off the edge of the bed, or sometimes if I get up and just walk around just a little bit, it relieves the ache. You can also develop into a kind of a chronic numbness, or eventually if it gets too bad, you can develop weakness. So what are the physical signs, or what are the signs of PAD? So decreased hair growth. People with severe PAD generally don't have any hair in the bottom part of their calves and their ankles and their feet. The skin becomes shiny, the feet can become cool. Coolness of the feet can be due to both arterial disease or vein disease. And vein disease is another entire topic, and it's another one of my specialties, but it's not the topic of today. It'll be one of those ones in August or whenever we pick it up again. The cool feet can be arterial or vein disease. Decreased pulses is something we generally perceive, or primary care practitioner may notice when they're doing a general physical exam. You can get bluish discoloration. That's another one of those signs that can be from artery or vein disease. Sores on the toes or heels that don't heal. And then the worst thing is if you can get gangrene. That's a blackness of usually the tips of the digits. So why is PAD so important, and why do we make such a big deal about it? If 40% of people are asymptomatic, then right? But so the problem is that people that have PAD have heart attacks and strokes. So there's a very, very strong association between PAD and the future development of a heart attack or stroke. And if we can identify the people that have PAD, even if you're asymptomatic, then we can do a lot of good. So that's kind of the name of the game. So from the time that you're diagnosed with PAD, in one very large study, they showed that 5 years after the diagnosis, 5 to 10% of people have an amputation of some sort. 20% of people have suffered a heart attack or stroke, and 15 to 30% of people are dead 5 years after the diagnosis. And 75% of those deaths are cardiovascular in origin, either a fatal heart attack or a fatal stroke. That's a big percentage, especially if you're asymptomatic, you have no symptoms, and you don't even really have it. So what do we do to treat this? So the first thing, once we identify PAD, is that we're going to, if you're not already on a statin drug, we're going to get you on one. If you're not on a low-dose baby aspirin, we don't give aspirin to babies anymore, but it still somehow has that terminology. 81 milligrams of aspirin we use to treat this. And you may have seen the news or news about the recent study that showed that aspirin is not good. People got the impression that it's not good. The point of that whole study was that aspirin is not good for people that don't have cardiovascular disease. The point in what we've known for a long time is aspirin is extremely good for people who have cardiovascular disease. So if you don't have plaque buildup in your body, there's really no reason to be on aspirin. If you have plaque buildup in your body, there's a really good reason to be on aspirin. And 81 milligrams is all it takes. So the aspirin puts a braking system on that clotting process. So if you do get a clot in one of the, or a tear in the beginning of a microclot in one of the vessels, it keeps that under control so it doesn't get too big. The statin drug, which would be like a Lipitor, which is atorvastatin, or Crestor, which is rosuvastatin, what that does is it helps to modify this plaque, and that's super important. So it takes a soft plaque that's prone to getting a tear in the wall, and it turns it into more of a hard, stable plaque. It also creates a thickening to this cap, and this cap becomes tougher, so it's less likely to rupture. So this is really, really important in heart arteries. That's one of the main ways that we can prevent heart attacks, aside from procedures. It's the best way to prevent heart attack, really. So then there's the other things, the things that cause the plaque to be worse, the smoking, diabetes, hypertension. So we know we always want to be aggressive about these things, but we really want to be aggressive if we know that you have plaque. So we're going to really harp on the smoking, no smoking. We're going to be aggressively treat the diabetes and aggressively treat the blood pressure, just to try to modify those risk factors. So what's the goal? The goal is we're trying to prevent amputations, we're trying to prevent heart attacks, trying to prevent strokes, and trying to prevent deaths. So we're trying to grab that 40% of people who don't have any symptoms, and we're trying to prevent them from becoming that 15 to 30% of people dead in 5 years. So how do we find these people? There's simple tests that we can do in the office. This what's called an ankle brachial index can be done in a primary care physician's office, but it's more often done in a specialty office these days. The way medicine has gone and the way they've made patient visits shorter and shorter and shorter, it's very difficult to squeeze this kind of a test in the 15 minutes that's given a primary care doctor in their office, or 20, however they have it set up. But usually these things are ordered now, so they'll order an ankle brachial index, and we do that here. And basically all we do is we take the blood pressure in the arm, we take the blood pressure in the ankle, and we make a ratio, and the ratio of the blood pressure in the ankle to the blood pressure in the arm should be greater than 0.9. Really, very normal is greater than 1.0, acceptable is greater than 0.9. We also have what we call a vascular screening exam, a little bit more in depth, and this is something that we offer here as well. The ankle brachial index is included in that. There's also a carotid artery screening, so that's another place we can look for plaque because that artery is really close to the surface, so we can see it with very good detail. And then we also look for aortic aneurysms. So that's another screening. So this one's kind of a little bit more in depth. We can check 3 different places. A different kind of an arterial study that we do, we call this an arterial flow study. We have a machine that hooks up blood pressure cuffs all over all your arms and all down your legs, and we get all these blood pressures, and we can get the blood pressure in your thigh, the blood pressure above your knee, below your knee, and your ankle. We get the blood pressure in the toes, and we can get all these waveforms in all the arteries all the way down, and we can show that we can look at this and say very normal blood flow, no significant obstruction of flow. So this doesn't tell you if you have plaque, but this tells you if the blood is restricted. So this is more of a physiologic test. This is another physiologic test. So sometimes if a blockage is in a very large artery, like up in the pelvis, we might not be able to detect it with that first test. But the patient may still have symptoms. So we have treadmills here that we use for cardiac stress tests, but we also use them for vascular stress tests. So we'll put the blood pressure cuff on the ankle, walk on the treadmill, and we'll see what happens to the blood pressure in the ankle while you walk. So right after you walk, we check it again. And in this one ankle, the blood pressure dropped to 20% of the arm, and the other one stayed at 90% of the arm. So one leg was normal, and one leg obviously had a severe blockage in it. This is something we do quite a bit of this. Arterial Duplex is a different kind of test. This is what you saw, the handheld device that they had in the second two pictures when they were checking the carotid and checking the aorta. This is one that we can actually see the artery. You notice on those other ones we couldn't see the artery. This one you can, so you can see the artery with the blood flow in it. And we can measure the velocity of the blood flowing through there, and we know what it should look like and how fast it should be. So just like a radar gun when they're shooting on 41, trying to catch how fast you're going, this is a radar gun that we have that we can see how fast the blood is going through that artery. And it shouldn't move too fast. There's a certain speed that we know it should be. Once we want to find some more detailed anatomical data, we would, and this is especially if we think we want to do any kind of treatment, which I'll talk about in a second, treatment such as a stent or surgery. We do these CT scans and you can see the arteries with this. So this was a scan that was created off our machine back there, and it shows that this artery has a lot of calcium on it, but it's a good artery. This artery has 100% blockage right there, and you can see this is a different reformat, that blockage right there. So it's not probably super easy for you to recognize that, but for us, we're used to reading these things. So what do you do to treat this? So if you have symptomatic PAD, meaning that you get cramps when you walk, you get tightness when you walk, believe it or not, the best thing to do is walk more. So walking more is the first line treatment for PAD. And what that does is it not only trains the muscles to be more efficient, so you want the muscles to use and need less oxygen. So if they're more trained and stronger and used to exercise, they won't need as much oxygen. They won't produce as much lactic acid. The other thing is walking will help you develop collateral circulation, which means that the blood gets around through smaller arteries and the blood actually flows better. It may not be through that artery if it's 100% blocked, but it'll get around better. We do have medications that we use which will improve walking distance. So if you're able to walk 50 feet, we can put you on a medicine that might allow you to walk 100 feet before you have to stop and rest. So if we put you on a walking program, you may have better luck, and it may be less, or maybe more tolerable, less painful, if we put you on a medication that helps you to be able to walk farther between each time you have to rest. So if you have tightness and it gets so bad that you have to stop, then you stop. Then you wait until it goes away, and then you walk more. And usually each additional walking session, you can walk a little bit further. And then selective revascularization means sometimes we take people for angiograms, sometimes we would put stents, and there's bypass surgery that can also be done. So angiograms and stents is kind of part of my specialty. And what we do for that is if you have a blockage, we're able to slip a wire through there. That wire has a balloon wrapped on it, and this balloon happens to have a stent on the balloon. So sometimes we have balloons that don't have stents, sometimes we have balloons that have stents. But we can install the stent inside that artery and push that plaque out to the side and allow the blood to flow back through normally again. Similar to what we do in the heart, when someone's having a heart attack and we can put a stent in there, we can do that same thing with the leg. They're just a lot bigger stents. This is how we put in stents. This is what it looks like. This is a 100% blockage of the artery that goes to the left leg. It should be a mirror image of this over here. And this is after a wire's gone through the blockage and after we ballooned it open and put a stent and basically recreated that artery there on the left side. This is another one. This one's in the thigh. And actually where this artery, origin of this artery, it splits in two, right? The femoral artery splits in two, basically right there at the head of the femur. And one should run down this way. That's the main artery that runs right down the leg, and then another one runs to the thigh muscle here. So you can see 100% blockage right there. That's the tip of it. And then it picks up again there. And this is after getting a wire through it. And this one, actually, we drilled out and removed a lot of the plaque and then ballooned it open. Just the last example of one. This is an artery that had a clot that went to it. So this is all clot. This is after vacuuming the clot out, and then this is after vacuuming the clot out and reballooning the artery open. There's a lot of different procedures we do like this. Then if you're unable to do anything with balloons or stents, then there are vascular surgeons that we work closely with that we make referrals to. And there's a surgical bypass that they can do to take a vein often and get it around the blockage and sew in to the other end of the blockage. So basically the formula for treating PAD, you want to have early detection, specialized imaging, you want to have medicines to prevent smoking cessation is extremely important, walking program, I say therapeutic medications to help you walk farther, and then selective revascularization procedures. The first 4 of these are really to prevent heart attack, stroke, and death, and the last 3 are to treat symptoms. And that's really how it boils down. And that's it. And any questions, if you have questions? Sure.
Do you recommend something like this in conjunction with walking?
Anything,
Could you repeat
yeah.
the question
This
so
is-
people in the back can hear?
yeah, it's a exercise device that you can use sitting on a chair or on a couch, I believe, it, like this with your feet, right? Yeah. Anything that's going to increase the circulation in your leg is going to help for PAD. It's going to help with all these things I said. So yeah, not everybody can get up and walk. Maybe have hip problem, knee problem, gout. Maybe if this is the best you can do is work your foot up and down, that's still a repetitive process. Using that calf muscle is going to increase the circulation and it's going to help. Stationary bike, same thing. The stationary bike tends to use more your thigh muscles than it does your calves. So it doesn't really have the same effect on the claudication symptoms as walking or something like that would probably be good.
I tried that, my knees wouldn't take it.
The bike?
The bike.
Yeah. Sure.
Those surgical procedures, are they all performed in this building, or do some require a hospital visit?
Currently, they all require hospital visits. We do vein procedures in this building, which will be, like I said, a separate topic. But the arterial procedures are still currently done in the hospital.
What are the current vasodilators you use?
We really don't use vasodilators for the treatment of PAD very much. The only medicine we really use, it's called cilostazol. In a way, it is a little bit of a vasodilator for microvessels, but not a vasodilator like we would use for blood pressure or the heart. It's not one of the typical ones. It works in a little bit different ways. Sure.
Is doing steered better than walking?
I don't think it's better than walking. It's probably similar. Whatever you can do.
Hurts more.
Sure. Yeah.
Can scar tissue, like from a new knee and new hip, can scar tissue cause this?
Scar tissue from a surgical procedure like a knee replacement or a hip replacement cannot cause this.
Okay.
No.
I've been screened and I'm EBI of 0.79 and 0.91, so I'm well over water. However, I'm also stage 4 CKD.
Right.
They don't paint a very good picture for someone who has the two. If you have just one or the other, it's not too bad, but when you have both, they paint a very dark picture.
Those are two of the higher up on the list risk factors for heart attack and stroke, certainly. The medicines that we give to people to prevent are very, very important, and they're very effective. So the key is to know you have it. The worst thing is to not know you have these things.
I know I've got
If
it.
you know you have them, then you can get on the appropriate regimen and we can make the best out of it.
Well, see, I can't have a MRI or a CAT scan because the contrast dye will kill the kidney.
Right, maybe, but the key is the medications more than anything. It's really the statin drug and the low-dose aspirin are the most important.
I take 2 of those aspirin a day.
That's the important
I
thing.
walk 30 minutes a day, 30 minutes a day for the last 6 months.
That's the best you can do. Yeah.
Does it have anything to do with all the varicose veins?
No. Arterial disease and venous disease have completely separate causes. Varicose veins, like I said, it's another one of my specialties. I've started a venous program here. I started one out in Chicago. And this one's going to be growing, and we'll be doing all the venous procedures here and the testing. We've trained all the techs to do all the venous testing. But it's hard for me to put those two talks together because people fall asleep.
Doctor, talking low dose aspirin, but is other meds, Eliquis, the same thing?
Eliquis is more of a blood thinner, and it probably does have some protection for PAD. Where it fits is not quite certain yet, but it'll probably be known soon. There is some evidence that it's probably going to be one of the players. And sometimes we would recommend that you take Eliquis and a low-dose aspirin, sometimes not. It depends on how many different medical and cardiovascular problems you have. And the real answer to that question is probably going to be coming in the next year or two. Yeah.
My question is probably more for the vein, in the vein thing.
Mm-hmm.
But what about severe Charley horses and the feeling of hot water running down your veins inside?
Charley horses, especially at night, are usually related to vein disease, certainly more than artery disease. Really bad artery disease can also cause leg cramps at night, or when you're sitting and doing nothing. But I feel like that's more of a venous symptom that causes that. And the water symptom running down your leg, veins can cause all sorts of weird sensations in your leg, from tingling to numbness to weird pains or a whole host of weird feelings. Yeah.
Are you the group of physicians who left Appleton Medical Center, Theta Care, Beach Street about a year or less ago, and can you discuss that?
We are.
Kind of. It's kind of like the politics of medicine that I heard. Was it really, and if so, I don't know if any of us really know the truth. What the heck really happened over there? Can you go into that?
Sure. Basically, when I wasn't with the group when they joined Theta Care, I came from a group of physicians that was private, just like this group is currently. When I came up here 3 years ago, they were already employed by Theta Care. That was an agreement that seemed to be the right thing to do at the time, from what they say, and Larry was partially involved in that at the time. As it went, the way it was set up, there were governance committees that were set in place for various day-to-day decisions, and then there was a governance committee for more of the higher type decisions within the cardiovascular department. The physicians were an intricate part of those committees, those governance committees, and how the cardiovascular division was run. And as the years went on, and especially more recently, we felt that our position within those committees was largely ignored. And we were having less and less of a say on how the cardiovascular division was run. And as that cooperation that was set up became eroded, we as physicians had less and less faith in our place within that organization. We had the opportunity that was written into our contract to dissolve the agreement. And we all, 100% of us, decided that that's what we wanted to do. And the reason was basically all about decision-making within the cardiovascular division. We feel that medicine should be practiced with the patient in mind. We feel that it should be more with the patient need than financially driven. We feel that decreasing the amount of time we have with patients or increasing the amount of tests that we order is not the right way to practice medicine unless it's the right thing for the patient. So we want to be able to practice medicine exactly the way that we feel that is in our hearts, that we want to practice it and we feel is right. It was getting to the point where we didn't feel like our goals were in line with other goals, and we felt like in order for us to be able to continue to practice medicine the way we wanted to practice it, we were going to have to go back to the way it used to be, where we were an independent practice. And basically, an independent practice means that you serve all patients, all insurance companies, and all hospitals. So that's the goal that we're striving for, and we want to be able to do that on our terms.
Can you give us an example of your decisions were not acceptable by way of the people in charge? And were those people also MDs?
The committees that I speak of are partially MDs and partially leadership. And leadership within the non-physician leadership.
Just politics 101 kind of there?
So these committees were intentionally set up to be basically half physicians and half theta care non-physician leadership. And decisions within those committees are supposed to be honored, and there are certain rules if one of those decisions is going to be overridden. And I'm not going to get into too many details, but there were many directions of decisions that were made in those committees that were basically shot down without the proper processes.
Were you all replaced with other people? Were you all replaced with other people in your own specialty?
It's very hard to recruit people here. In a group our size, we have several subspecialties within our group. We have interventional cardiologists like myself. We have cardiologists that specialize in imaging, like all this stuff that I was showing you. We have cardiologists that specialize in electrophysiology, which is like an electrical heart specialty. We're, in one way, shape, or form, almost always in a recruiting process for our group. There are people of various ages in our group, people that are planning their retirements sometime in the next 1 to 5 years. So we're always looking on the horizon to recruit. Recruiting is difficult in medicine, especially in cardiology and in subspecialty medicine. So it takes a long time to get someone to move states or to come out of fellowship and come practice. And if you do get someone to come out of fellowship and come practice, it takes years to get them really up and running where you feel like they can be independently doing surgeries like this without us having to be somewhere with our eyes on them. So recruiting is always challenging. We are recruiting for our group almost all the time. Theta Care is now recruiting to try to build a new group. But it takes literally 10 to 20 to 30 years to put together a good group of physicians. And that's because people know people from various parts of the country, and eventually you start to get a really good cohesive group. Starting over with that process is very, very difficult, and it'll take a long time to reduplicate that. So we currently have privileges at Theta Care, Appleton, we have privileges at Nina, we have patients in the hospital all the time. We usually have somewhere between 15 and 30 patients at Appleton. There's at least one, if not two of us over there every day, sometimes three, taking care of all the people in the hospital. We have one person at Nina taking care of them, taking care of the patients that are at Nina. We'll eventually be on staff at other hospitals, and we'll have physicians going to those hospitals to take care of those patients. Like I said, we want to be able to take care of every single patient in the region, every single insurance company, and every single hospital.
So you are in effect walking in the same door you walked out on East Street?
Absolutely, yeah.
What's the camaraderie like with the other people that you see walking down the hall?
All of our old associates, we get along with like peas in a pod.
In terms of staff.
Staff,
Yeah.
all the staff of Theta Care.
You were asking about the other positions.
Anybody that you
every single person that we've ever worked with treats us the same or better than they ever have.
How about the people that cause you to leave? Do you still see them? You all friends with each other? Those are the politics that you could ask, because most of us all heard rumors. I did. I heard, oh, one of those doctors got fired. That sounds nasty.
Right.
But that's what the people on the street will say. And did you get fired?
No way.
Okay. How do you, now, have you heard, or what have you heard from the public about your departures?
People, the public has not only been underinformed, they've been malinformed. So a lot of the restrictions on us saying things had to do with that we were still employed there up until March 31st. We had no ability to speak our side of the story up until April 1st. So there was a pretty long head start of malinformation before we were able to get our side of the story out. And getting our side of the story out is not always that easy. So, I mean, we can, word of mouth, talks like this. There's been a couple of things in the newspaper, but it's difficult to make that up after it's been out there for so long. But we're trying. But we're also focusing on just doing exceptional medicine, because that's really what we're best at. We're better at seeing patients and taking care of this stuff than we are at blabbing our mouths in the newspaper. So, to some extent, we have to do what we're good at.
Good answers, thank you.
Sure. Yeah.
Do you get any veterans coming here because they can't be served at the VA hospital in Milwaukee?
We get lots of veterans, but it's not because they can't be served at the VA hospital in Milwaukee. It's more because most people like to have a cardiologist in close proximity, and we work with a lot of VAs in that we'll see patients, and then they may also have a cardiologist at the VA. A lot of veterans like to get their medicines through the VA, so they'll come and we may do a lot of the testing, or we may do their local care, but then whatever, once a year or twice a year, they may make that trip to the VA just to make sure that they're still in the system, getting their medications. There's a lot of different ways it works, but it's usually not because of lack of VA access. Just more to do with the locations.
You know, you showed the picture of the test that was done on the neck and on the chest. Why not just go right to the ultrasound instead of going step by step by step to determine birth?
So we have ultrasound.
Repeat that for the public.
Yeah, so she wonders, why do we have so many tests and so many steps? Each test has its own little bit of information it gives us, its own niche, kind of. The screening test is very economical. It's $50 to get that test where you get the blood pressure in your legs done, the ultrasound of your belly, and the ultrasound of your carotid. We get a lot of information from that. If that's normal, which oftentimes it is, then you're kind of done. You don't have to do any expensive tests. So all the other tests are more in depth. They take longer. They go through your insurance company billing. They're certainly more expensive because they're more tedious, time-consuming. But each one of those other tests, beyond the 2 screening tests, has a certain purpose why we order it. Whether we want to see the vessel, whether we want to measure the velocity, whether we want the one that looks like the man with all the red things running down the leg. Each one of those, to me, has its own special purpose. The CT scan, we get to see the arteries, but we don't get to know how much impediment to blood flow there is. So that gives us anatomic information, but it doesn't give us physiologic blood flow information. So we may see a blockage on that, but we may not know what the significance of it is. So the hemodynamics, the physics of it, we need to know through some of the ultrasound testing. CT scan, you have to use contrast. And as he mentioned, contrast has its downsides. It's also more radiation. So anything with radiation or contrast, we always have to take those things into consideration.
Doctor, I have AFib on Eliquis. Should I avoid aspirin?
Not necessarily, but that's a decision that needs to be made in the office with your physician. We have many people that are on a low-dose aspirin and Eliquis, but it's for a very specific reason, usually because there's two very specific problems. So they're different. So, but that's a question for your doctor, you know, with the door closed, going over your specific file and what exactly problems you have.
I want to compliment you on the cost of the screening of $50. Because there's a commercial out there that's been advertising at churches and so on around the area. And I think their fee's $150 for the same thing.
Yeah. 50, right, Mike?
Yeah, we're 50.
Right.
Lowest in the country.
Really? Yeah, really?
Yeah.
Glad I said it, right?
So whether you're symptomatic or asymptomatic, can you do self-referral and?
Well, the screening test, anybody can walk in the door and schedule a screening test, yeah. That's a self-referral. Yeah, on call, sure. Yeah. Yeah.
If one aspirin is good, or two aspirin,
We used to think that, but not necessarily. Really one aspirin, there's very few things anymore that need two aspirin. One aspirin is almost always enough. The more aspirin you take, the more chance there is of bleeding complications, specifically ulcer disease in the stomach, peptic ulcer disease.
you take the coated aspirin.
Even with the coated aspirin, yeah. One more?
What prompts a choice between Eliquis and Xarelto?
It's very thin line between those two. It really doesn't much fit into the PAD talk, but the Xarelto is once a day, Eliquis is twice a day. The safety data on Eliquis is maybe slightly better than Xarelto for bleeding. Xarelto was the second drug to market, and it was the first one that was once a day. So it gained a lot of popularity because once a day drugs are nice for the convenience. Taking a drug twice a day, a lot of times people forget that second dose. I wouldn't say a lot of times, but maybe once a week. You may fall asleep in a chair and then wake up and go to bed and just forget. And we know that. That's just life. So drugs that are once a day tend to have better, we call it compliance, meaning the chance of you taking is higher. But a drug that's twice a day, like Eliquis, like I said, the safety profile when they put it through is slightly better. All right.